Welcome to the Masters Bikini and Fit Model podcast, a show created to spotlight, celebrate, and connect the women who are proving that strong, feminine, elite physiques do not expire with age. I'm your host, Lacy Green, IFBB Pro, and I am joined by my co-host, Kyla, Faye, IFBB Pro. Together, we're here to highlight the stories, experiences, conversations, and community behind the women of Masters Bikini and Fit Model. This podcast is for the women who are still dreaming, still competing, still growing, and still showing up with purpose, because strong does not expire and dreams do not retire. Welcome to the show. Before we jump into today's episode, I want to tell you about the Masters Bikini and Fit Model Collective. This is a private community created specifically for Masters Bikini and Fit Model athletes, from future competitors to seasoned IFBB pros. Inside, you'll find education, exclusive resources, live monthly huddles, competition support, and genuine connection with the women who understand this journey. The collective officially opens September 3rd. To get early access, join the waitlist now by clicking the link in the show notes. We would love to welcome you. Hi guys, welcome back to the Masters Bikini and Fit Model podcast. I'm your host, Lacy Green, and with me is my beautiful co-host, Kyla Faye. And we have a special guest again today for you guys.
Yes, today's guest is one I'm especially excited about because this conversation is going to be incredibly relevant to so many women in our master's community. We're joined by Dr. Courtney O'Brien, a board-certified family medicine and sports medicine physician with San Diego Sports Medicine and Family Health Center. Dr. O'Brien has a special passion for women's health and helping women navigate perimenopause and menopause with evidence-based, individualized care. Her clinical experience includes menopause management, hormone replacement therapy, medical weight management, preventative medicine, and sports medicine, which makes her such an amazing resource for women like us who want to continue feeling strong, healthy, athletic, and like ourselves as our bodies change. And she understands athletes from both sides of the exam room, because before becoming a physician, Dr. O'Brien was a collegiate athlete herself, playing varsity soccer at Indiana University. And what I especially love about her approach is her belief that women should be active participants in their healthcare, understanding their options, asking questions, advocating for themselves, instead of simply accepting that the symptoms of midlife are something they just have to live with. And on a personal note, Dr. O'Brien is actually my own primary care physician and the doctor helping me navigate my women's health and hormones. So I'm extra excited to get to have this conversation with her today. So Dr. O'Brien, welcome to the Masters Bikini and Fit Model podcast. We're so happy to have you.
Thank you very much. It's very good to be here.
Yeah, it's awesome. Dr. O'Brien knows my background in competing and how when you start to navigate hormones, this is where my thought process went at first is, oh my gosh, I compete. I have to be at a certain physique level, certain leanness, certain conditioning. And I was worried that navigating these hormones, I actually delayed some of my HRT starting that therapy because I was afraid of gaining weight or afraid it would change my body composition. So I kind of want to start with that, with when is a good time to start, and should women fear that? Because I think we do. I think that's a normal fear in or out of competing. I think women would fear that.
Yeah, absolutely. And it's a valid concern, something I talk about every day in patient rooms. But I think the first question you asked something is about like kind of when should we start thinking about this? And so this kind of turns back on us, just women individually, is saying, we have data about optimum start times around menopause, but that tends to be more looking at kind of like 50 to 59 years old and saying that we have data that supports starting therapy in this kind of opportunistic window for best benefit when it comes to cardiovascular risk preventative care as we age. But each woman is going to come through this journey at a very different rate and pace and timing, right? We look at any woman, in her late 30s starting perimenopause symptoms is very normal, which, I think a lot of people think, oh my gosh, that's so early. I had a 2-year-old child when I started having hot flashes, and I thought, this is crazy. Like, this can't be. So coming to the timing of it really has to be when you start noticing, hey, something's different. Something, and not every woman could put her finger on it. Like, I'm sweating through my sheets, or, my brain is foggy, or God, I'm just annoyed by everything. Sometimes it's just this, like, I don't feel like myself. And that's when you should start the conversation with your physician, provider, whatever, to start bringing this up, saying, hey, I'm noticing these things and it's happening, these are new things, or I used to be able to manage this and now it's feeling overwhelming. So for some women that could be in their late 30s, or maybe you've been experiencing these things and you feel like, I've been blaming it on other stuff. I'm busy, I'm stressed out, works hard, I've got young kids, my parents are aging, something like that. But, I would say the sooner the better having the conversation. And then that kind of propels us forward into how we kind of evaluate those symptoms and try to kind of come up with a treatment plan that works best for each woman, right? Because although there are there are a lot of things that are very kind of classical, each woman is going to have a very individual journey.
Yeah. Yeah. And that's kind of what I went through. The thing that really like hooked me on Dr. O'Brien was because I kept talking about optimal, blood work results, right? Like we want to be in this, you keep hearing this, like you want to be in the optimal position with your markers and blood work. And she was like, yeah. And like, how do you feel? Like, how is it that you feel? Like, because yes, we look at all of those things. It's kind of like when I tell my clients, like the scale is a data point. How do you feel? That's really important. And that's where it clicked with me, is like, I just don't feel like myself. We started going, okay, what can we start with? Because I didn't want to throw everything out. So I guess my next question with this is like, we started with testosterone for me. That was something, because I was like negative, like a lot, negative a lot. Yeah. Let's put it that way, that very inarticulate way that I just put it. But so where did women start? How, where do they start with that? How do you navigate them through? Okay. I guess take them through, like, kind of, I guess me as an example, like we started with testosterone.
Yeah. And I think, so before we even get to like pharmacology stuff, right, we're talking about kind of someone's lifestyle, right? And again, everyone kind of comes in at a different starting place with different experience, right? And so you think about the foundational things that as women, as humans, looking to be optimal in our health and wellness, right? So what are those building blocks? Because those are the things you really have to look at, kind of break down, which is like, what is your sleeping pattern like? And that can then dive in women to symptoms, right? Oh, I'm hot at night, or I can't fall asleep, or I wake up and my brain is really busy. So we're diving into those questions, right? So how do we optimize your sleep? How are you moving your body? Like, we know critical things happen metabolically and physiologically during perimenopause and menopause, as far as our lean muscle mass, as far as bone health, as far as body composition changes, right? So how are we moving our body? So digging into some of those, some women are saying like, well, I'd love to move more, but my sleep is awful. So then I'm fatigued, or I have a lot of joint pain and it limits me. How am I fueling my body, right? Well, I'm not sleeping well, so I'm craving a ton of carbs. My life is busy. I'm like grab and go. How are you managing your stressors? That's the other thing. That's another big thing. And then, all the things that we know don't really help promote healthy lifestyle. So like, what are our drinking habits? Like how are we treating ourselves? How are we restoring ourselves after, stressful work days and dealing with all the stuff? So foundationally, like, I start with the ground, like at the building block level of like sleep, nutrition, exercise, stress management, and kind of those like, no-nos that we know we shouldn't be doing. So that, I think, is like, that's my like start point. Now, for some people that come in and they're like, I have a huge portion of patients that are like, I don't think I could do better. Like, I've never been this cognizant of my nutrition. I've never been this cognizant of my exercise. I'm doing more than I ever have. Or, I'm trying to get to sleep. I have an app. I listen to meditation. I take these supplements, blah, blah, blah. And I'm not getting there. And that's when we have to start digging in a little bit more to, okay, how does this hormone shift, and can we support those through therapy, right? So different options for hormone therapy. So, without a doubt, building block is lifestyle. So like breaking all of those categories down, and really digging into each of those. Because if a woman's like, I'm sleeping great, but I feel like unmotivated and down. And so then you're starting to go, well, is there some mental health stuff going on? So it helps me to kind of break down like where the starting point is, right? Is like looking at those lifestyle things. And then we start to get more into the nitty gritty of, hormone replacement therapy and things like that. And then, obviously it's a big conversation. So if you have specific questions or how you want me to break that down, like.
Yeah, I guess, it's such a broad thing. Like, I feel like, oh my
Totally.
gosh, we could have a part two with Courtney
Yeah, it
O'Brien.
could be weeks.
Yeah. There's just so much. So let's break it down, like with what hormones do women need? Because you'll find like, okay, I got to be on estrogen, progesterone, testosterone. But maybe not everyone needs to be on all those things.
Yeah.
So
okay.
maybe start with that.
Yeah, let's break it down to like kind of the simple. So when we're talking about, what are our reproductive hormones, right? So estrogen, progesterone, testosterone, those are all in that bucket. When we're talking about the symptomatology of perimenopause and menopause, a lot of those things are coming not necessarily just from low levels, but they're coming from this like volatile, like bouncing back and forth of these levels, right? So in our young reproductive years, we've got this pretty nice pattern of rises and falls in these levels in a cycle, right? Which we all kind of think about, oh yeah, even when I was younger, maybe right before my period, I got a little moody or I felt hungrier or my sleep wasn't as good, because you have this natural rise and fall of estrogen and progesterone during these times. But, in perimenopause, it's very much chaotic, right? So you've got these rises and falls not occurring on this nice regular cycle. And so that's driving a lot of the symptomatology. And so when we're talking about what do women need? Well, estrogen is driving most of the symptoms of menopause or perimenopause and menopause, right? So this kind of volatile signaling, lower levels of circulating estrogen, that are causing chaos in all the systems that are used to seeing this very consistent, reliable stimulation that keeps everything kind of working as it should. Like I always joke, like when we were 20, we weren't walking around being like, oh, my estrogen feels so good. It's like, no, that was, you were taking it for granted because that was the standard, right? It becomes inconsistent that we start going like, what is that, right? And so, for most women in perimenopause and menopause, making sure that they're stimulating those estrogen receptors that live in every single body system from the tip of our head to the tip of our toe is probably going to be the most useful as far as like kind of righting the ship as far as the symptoms go. Now, if you're a woman that has a uterus, meaning you have not had a hysterectomy, and this is even if you've had an endometrial ablation or let's say maybe you have a Mirena IUD, that's kind of an exception, but a hormonal IUD. If you have a uterus, progesterone has to be given in hormone therapy with estrogen. So the role of the progesterone is protecting the endometrial lining and the endometrium from overstimulation from exogenous estrogen, which could cause it to become thickened and create a setup for possible an endometrial cancer. Right. So progesterone comes with estrogen. Now, progesterone is kind of known as the calming hormone. For a lot of women, it has a secondary benefit in modern menopause therapy of it. It breaks down in the body to something called pregnenolone, which crosses the blood-brain barrier and stimulates your GABA receptors. So we know that as estrogen goes away and that its interplay with dopamine and GABA at the level of the brain can cause, higher anxiety, depression, sleep issues, etc. So you can get a nice benefit from having systemic progesterone on board. So that's kind of how estrogen and progesterone play together. When we talk about testosterone, it's an interesting one because it's decreasing linearly, right? So we think of estrogen and progesterone in this kind of tug of war during perimenopause and into menopause where we've got this volatile signaling causing these highs and lows and swings, whereas testosterone is really kind of coming down from our peak in our early 20s, right? So we peak in our early 20s and then it's a linear decline. It just so happens that perimenopause and menopause hit that testosterone curve at a lower point. So if peaking is at 20, early 20s, then 40 is 50% of that peak. If most of us are coming into perimenopause and menopause in our 40s and 50s, we're down, already 50 to maybe 60% of what that peak was. Now, if your peak was lower to begin with, you could be like in a situation where you're like, non-existent circulating testosterone. And for some women, that has a huge effect on things like mood, brain fog, libido. Testosterone is a brain hormone. We think a lot about it, I think, in terms of like our muscle or like like men and sexual functionality and things like that. But it plays a huge role in just cognitive function in general. And so we can start to see some of these things like, the brain fog and the forgetfulness and all of that kind of stuff. And while it's not just testosterone, if that is something that women are continuing to struggle with, or they find that to be like the peak kind of complaint, supplementing that for some women can have some major benefit, especially if it's synergistically used with estrogen and progesterone during that time.
That testosterone thing was helpful to me thinking
Yes.
about that.
I was just going to say that. That's so
Yeah.
funny. I was just going to say, like, the cognitive, it's helped me most with that.
Mhm.
That was my first kind of like how you described, you feel like something's off. You don't know what. For me, it was the brain fog. And
Yeah.
then when I started just testosterone therapy, very low dose, but it's like one day I woke up and like everything was clear and it was amazing. And I don't know how many years I lived like that.
Yeah. Yeah. And, I think a lot of it's definitely, as it stands right now today, FDA approved off label for use in hypoactive sexual desire disorder. Which I know for some women, they go like, well, that's not me, or I don't want to even go down that road. Like, I don't want to talk about that with someone like a doctor, or like, I'm not even going to bring it up. Anecdotally, we're just seeing so much more from the cognitive standpoint in women that are being supplemented. Even if they started it for, my libido is in the tank, they may not have that huge, robust libido response, but they may go like, man, my ability to make decisions, my clarity, feeling like I've got like a little more drive and push, And so those are things that it's like, it's maybe not why they started it, but what a wonderful benefit, especially at this time in life when, a lot of us need that because there's a lot going on in our 40s and early 50s.
Yeah. I mean, I just was like, it's funny because you're like, we think of it as like men in the gym with the testosterone. But I'm not
Sure.
going to lie. I think that helped me in the gym too a little
Yeah.
bit.
Well,
Okay,
and yes,
'cause-
it's valid. It's valid, right? I mean, there's going to be more, there is some data coming out now, and I think it'll be more robust, later in the year. I think there's a paper coming out, but about bone health, right? And testosterone, because of, all of those attachments of our muscles to bones impact the way, right, that reactivity, right, reactive stress. Like when we lift, that's why resistance training is such a powerhouse thing for women in midlife to do, because of the way that it helps that bony turnover, right? And so if you have better muscle recovery on testosterone, if you have better stamina, if you're able to push yourself and have those gains, you're going to be increasing the demand on your bone, which is going to help with turnover and help bone density. And so I think, there's more to come on testosterone as it becomes more utilized in hormone therapy. For sure.
I take the progesterone and estrogen gel.
Mhm.
And I'm on the testosterone gel, and I've been on that since last October. But I was dealing with hot flashes maybe like once every blue moon, and they weren't that bad. But then I went on progesterone, estrogen, and I started getting not horrible ones, but more frequent but I know the hormones are like fluctuating, and I'm the most impatient person on the literal planet. So I'm like, what is happening? I'm stopping all of it. And then my husband's like, I think you should email your doctor. So I did.
Yeah, good idea.
And, Courtney's so great because she's like, you definitely should give it some more time, or we could do that. She gives you options. She never just tells you she never comes at you she's going to tell you what to do and what she professionally thinks you should do, but she's going to talk you through it, and you're part of the conversation, which I really appreciate. So can you kind of now, there's kind of two-part question. I do this sometimes. I put too many questions in one, but the question, I guess, one is how should we be taking this? And different providers we've talked about suggest different things, right? Should you give it some time? Because I think some women I'm a freak out woman. I'm like, did I gain a pound from the estrogen? I'm off. I'm done. I'm not doing it. But give it some time. Explain to us how it can take some time, because some women, I know testosterone can work pretty fast, and some women it takes months. For me, it took a couple months. So I guess two-part, how they should take it and how much time it takes.
Yeah. So part one to that. So how, right? So a lot of that is that conversation you're having with your provider about your individual risks, desires, et cetera, because the reality is we have different ways we can get hormone therapy to women, right? And so, and again, there are certain things that I don't do within my practice, which it's one of those things where it's I don't have, it's not I can't believe people do X, Y, or Z. It's like, you know what? We've been really limited to a lot of alternative ways to get hormone therapy, to be quite honest, over the last 2.5 decades with black box warnings and just undereducated providers, right? So if women are feeling good on their therapy and it's safe, you know, I'm like, okay, great. That's not for me to come in and be like, well, you shouldn't do this or you should do this or whatever. But in discussing individual risk, right? So, you know, we have the two main ways that we get estrogen, and at least in my practice, FDA approved ways that we do it are either oral, right? So you're taking a pill, or something through your skin, which we call transdermal, the fancy way to say that. And so oral estrogen, these are looking at menopause therapy hormones, right? So estradiol, these are body identical hormones, like the FDA approved medications you get at your CVS or Costco or whatever, right? These are structurally as close to what we can get pharmacologically as to what your ovaries are making when they're doing their thing. And so women shouldn't be afraid that that is something that's, everything is synthetic, right? Everything we make is synthetic. So yes, you hear the word synthetic and someone, but it's like, these are mimicking exogenous mimickers of what your ovaries are making. So oral estrogen, pill that you take every day. There are some exclusions, right? So women that have had a history of blood clots, and we don't really know why. Women that have migraines with aura, meaning they see like weird, like visual stigma and stuff before their migraines. You know, women that are overweight, right? That's a risk factor for clot. So that in and of itself can be limiting. If you have liver disease. So, I mean, obviously these are things you're going to talk to your provider, and hopefully they know your background enough to say like you are, or, you're not a great candidate for using an oral estrogen. So similarly with progesterone, so we have two kind of ways that progesterone gets in that we have through FDA approval, and one is that oral micronized progesterone. And so again, this is something you're taking orally. Not as many contraindications as far as taking an oral pill. Pretty safe for most women. Something to be aware about is that there's oftentimes some type of they use like a peanut oil in the suspension. So if you're a peanut allergy person, just something to take note of. Make sure you have that conversation with your provider and see if maybe they have to go to an alternative version, or you can compound it too without that. But when we're talking about transdermal, so through the skin estrogen, we've got gels, and there's different varieties of that. Almost all of this hormone therapy is generic. We have very few branded hormone therapies anymore. So, there's different names to those gels, but estradiol gel, there's something called the Eva Mist, which is a spray. And there's also a vaginal ring that supplies systemic hormone therapy, right? So we have one that's for local, one that's for systemic. And so transdermal estrogen bypasses your first liver metabolism. Very safe. No increased risk of clot compared to your baseline. We don't see that it has such an effect on possibly like your liver enzymes. Transdermal estrogen also kind of bypasses this mechanism that increases this protein your liver makes called sex hormone binding globulin. So the more of this protein, the more your testosterone is bound to this. And so that can be problematic as far as free testosterone for women that maybe are having low libido. Giving them an oral estrogen, that may make that issue more profound. So just things to consider, right? This is why it's important that you're seeing someone that understands this when you're seeing a provider about menopause, that they can kind of walk you through it. So we've got oral, we've got transdermal. Patches are another one. So right now we're in a nationwide shortage, I don't know, patches, and we'll see, if anyone's going to pay attention to that and try to fix the problem.
Are we in a shortage of Viagra pills for men too? Or
never.
No?
We've actually never had one of those.
Probably not.
Not only that, that interestingly enough is the one medication that was the fastest medication ever to move through FDA approval.
I bet. But we're out of the patches. We're clean out of the patches, ladies.
Yeah.
That tells you right there who's in charge.
Yeah. So the oral through the skin, vaginal ring, paired with a progesterone that's oral. There's one patch, it's called Combi patch. So that has estrogen and progesterone in a transdermal delivery. So there's a lot of different ways, right? And then you go down the whole road of like compounded therapy, right? Going to compounding pharmacies. Now that's something that, I kind of use as like, if we can't find what we need for a woman through kind of the mainstream ways that I prescribe, it's something that we talk about, right? But again, that's, kind of a deeper level of saying like, I want to be able to know exactly what we're getting and have that be consistent. And for a lot of women, that consistency is the thing that we're looking for in hormone therapy. And so that can be, not as easy to follow in a compounding world, but those are options as well. I know women are getting pellet therapy and injectables and those kind of things, which, again, like I said, I'm usually able to find through kind of our standard FDA medications and options something that's going to work. But if not, those are also things that people are doing. I just would always say, I always have a question of like, well, if I go into a clinic or if I am seeing a provider and the first thing they say is like, well, you should do pellets, they're probably doing pellet therapy and that's what they do. And so you have to kind of be like, oh, you didn't talk to me about any other options. That seems kind of weird to be pigeonholed. So just as a consumer thinking like, are they also, are they selling me on this because that's how they make their money? Right. And is that the best thing for me? Right. And so some people do that and they like it, and like I said at the beginning, like I'm not here to poo poo anybody's journey, but just kind of having that like thought of like, okay, can I ask a second level question of like, why not, something that I can get my insurance to cover, at CVS.
With the gels, that's a daily thing. That's a
Sure.
daily
Yeah.
that's a daily thing. And someone I mean, I'm not gonna lie, it's annoying. Like, because the testosterone gel is real quick to dry and everything, and the estradiol gel is like I feel like I'm rubbing it on for 10 and I'm like I said, let's go back to Kyla being impatient. Maybe some wouldn't care at all. But, it's a daily rhythm, right? And you
Sure.
have to be consistent. So you have to like do it at the same time, like around the same time. You can't be like doing it one day at night, one day at the morning in the morning. So that timing factor. So I think maybe we're kind of in a society that like, okay, the least amount of work I have to do to get the best
Sure.
results.
Sure.
That's
Which
where
is
I
why
want to be.
the patches were
Yeah.
excellent because it was like,
Yeah.
I can think about that twice a week, which, but to the second part of your question, which was kind of timing, right? So getting started on therapy, right, is a huge hurdle in and of itself, right? Some women will wait years before someone will say like, you know what, I'm hearing you. This doesn't sound like you need 15 different interventions for your 15 symptoms. These might all be related. So that's step one, is getting over the hurdle of just someone saying like validating, yes, these symptoms are related to these shifts in your hormones and we can have a plan to treat that specifically. And so I will usually counsel patients. I say, hey, the first 2 weeks that you're on therapy, your body is going, hey, okay, what's this? What's going on? We're seeing these consistent stimulation to these receptors that, otherwise they're kind of just waiting and hoping. Especially if you're a woman who is kind of in menopause already, those may have been quite dormant for a minute. So the first 2 weeks, I kind of say you hold loosely to what happens. You may go, I have breast tenderness, or, I feel a little more emotionally sensitive to X, Y, or Z. Generally after, into that first month, you're kind of going like, okay, I'm paying attention, I'm noticing things, but I'm not really holding too tightly to like the end all be all of these effects. Usually into that second month, so down into the weeks 4, 5, 6, I'm kind of like telling women by the time we get through that almost that second month, we're probably seeing like what your benefit is going to be from this estrogen progestin combo. As you alluded to earlier, right? Testosterone can take more time. I have some women that, will continue to see benefit into the 3rd month, 4th month, 5th month. I mean, even up to 6 months is saying like it's a little better than it was last month when it comes to libido, brain fog, mood, motivation, those kind of things. And so, yeah, there's an element to patience for sure, right? And also just understanding if you are in perimenopause, there's volatility in the background, and that, as much as we like to we want everything to be like, just like steady Eddie, I can count on this, etc. It's chaos, right? And so we have to be cautious about trying to chase every high and low because those are going to be going on. Like we're not overriding your brain with hormone therapy. We're coming below that brain to ovary kind of push pull. And so if you're still actively having that push pull in perimenopause, we're not kind of overriding the computer, right? We're trying to say, okay, there's this roller coaster happening. We're trying to give you this off ramp that's a flat road, that's smooth, that's reliable. So those receptors, right, that are going like, where is this estrogen? are feeling like, okay, deep breath, we can relax, right? And so that takes time, right? Similar to like starting on antidepressant medications, et cetera, right? We're looking at, those receptors that are all cattywampus. It's going to take them time to realize, oh, this is reliable, steady stimulation. So patience.
That's
But
helpful because
yeah,
you don't, we always think, I'm doing this thing now. It should work right now.
right,
And
yeah,
it's helpful to hear, just be patient, stay consistent. Isn't it much like bodybuilding? Muscle does not grow fast.
right, yeah,
Stay
exactly.
consistent, keep doing the thing.
Yeah. Yeah. And also, in that same vein is if it's not working, it's okay to be like, I don't think this is working for me. Right. And, should you say that right away? Well, maybe not. But, I can think of one person and she's kind of burned into my brain that was like, I think this is worse. I'm way worse. And you just go like, well, I can't make sense of that physiologically. But you're telling me that, and I'm of the business of believing women when they say things to me. And so, you go, okay. But there's also, I have the patient that says, I put the patch on and I felt better. And you go, that's awesome. I'm so glad to hear that for you. That's placebo. That's placebo
Yeah.
effect. And, interestingly enough, placebo 30% of the time is effective. Right. And so you have to just caution those patients that say, hey, if you have this, if you're someone that, so strongly wants to believe this is it, and I felt amazingly better immediately, I can't make science sense. So I have to warn those patients, hey, there may be a come down on the other side where you go, wait, it's a weekend and now I'm starting to feel kind of wacky again. It's like, yeah, the newness has worn off. We've all taken the supplement or started the regimen where we thought, oh, this is life changing. And then very quickly realized like, I think I convinced myself it was, a little too early maybe. No.
Yes. Yeah. So I need to be patient. That's the moral of the story. So I'm going on
We
week
all
4.
need to be patient,
It works. I have this question in my head that keeps going. Can you explain perimenopause versus menopause?
Sure. Yeah. Very simple. It's very simple. And I mean, almost comically simple to the point where you'll go, huh? So menopause is a clinical definition. It's 12 consecutive months off of birth control with no period. The end. That's it. 12 consecutive months off of contraceptive hormones. So not on birth control, not with a Mirena, or a hormonal IUD, and not having a period. 12 months and 1 day, you are now menopausal. Anything before that, even month 11, no period, that's all perimenopause. And you can walk that back to when you maybe first started going like, maybe I feel off, right? And for some women, last period age of menopause is 51. So some women may, stop having a period at 51, menopause at 52. And then they look back and they go, you know what? I think I started feeling off when I was about 40. And you go, well, that's 12 years of perimenopause. So it's almost like retrospective to a certain degree. Now, when you're in it and you're in it, you're like, no, I know this is it. But yeah, it's just a clinical definition. So there is not a lab value that defines it. Now, there are women that are in situations where they don't have a period because they've had a hysterectomy, right? So if you have your uterus removed for whatever reason, you're not bleeding. And let's say you had that done in your early 40s. Some women will go, well, I don't know. I feel like something's off, but is it my hormones? Is it something else? I mean, and that's where it's important to, rule out other reasons that women don't feel good, right? It's like, you can have two things be true, right? You can have thyroid dysfunction. You can have anemia or a low ferritin level that's making you feel wiped out. Women can have pre-existing depression or anxiety, and that can be, rearing up during this time where we kind of lose a lot of our support system through our hormones. So you have to rule those things out. But in those women, you can look at estrogen levels. You can look at something called an FSH level, which is your follicle stimulating hormone. And that can give us an idea in those women if, let's say, not that you need it, right? I listen to them. They say, I'm having night sweats, hot flashes. I can't think. Everything's pissing me off. It's like, well, I mean, I'm happy to give you a test, but like, I still want to treat you, right? And so that's 12 months, no period, not on birth control, menopause.
Okay. And then measuring this is, because hormones, go like this,
Yeah.
and they're hard
Yep.
to. I'm using my hands, people, if you're
Yeah.
not on YouTube. They go up and down,
Yeah.
right? And
Yeah.
so
It's a roller
like
coaster.
we're about to check mine. It's kind of funny because I feel like I'm gonna start my period soon. For me, I've been on birth control for a long time, like the pill. Like I feel like I'm the only person on the planet that's still on birth control.
You're not. You're not. I can
I'm
I
like,
can
am I
say
the
that confidently.
this is crazy, but I like never had problems with it. And I'm one that I'm not rocking the boat. Like if it's working, I'm not gonna mess with it. But I know to have a better, journey with all of this, like I needed to get started. And so I'm on a progesterone I didn't even know this existed, that has a birth control component to it. So maybe you can speak to that a little bit. So I've been on this, progesterone, estrogen gel, like journey for 3 weeks. And then I'm assuming, because I'm feeling the symptoms of like bloating and, irritability and PMS, because I'm a big PMS girl. But I knew when that was coming with the birth control pill, like my period is coming on Wednesday, Thursday. I feel those symptoms kind of coming on, and they'll still come on with the progesterone pill that I'm on, right? And I'll still have a period, but I still keep taking the pill. And then I'm getting my blood work done to check my hormones on day 3 of my period. So I
Yeah.
think a lot of women are really confused by that.
Sure. Yeah. Well, so, and the reality is this, like I was saying, right? The perimenopause is a roller coaster. All right. It's this tug of war, push pull. As our ovulatory reserve goes down, the brain is still going to request the same thing every month, which is let's surge your estrogen, let's ovulate. That creates this kind of rise and fall of our hormones. Now, as the factory workers slowly leave the factory as far as estrogen goes, and that message is not received with the same amount of vigor that it once was, those levels are fluctuating. So the thing that I think is the most critical for women to understand is that checking hormone levels in perimenopause is a snapshot in time. It is not defining how badly you need to be on therapy, what you should or shouldn't be feeling. It is literally a snapshot, right? So for most women, I'm saying, if you look at the guidelines, right, the North American Menopause Society, who I'm certified through, or the European or whatever, there's not guidelines around checking levels, which is mind-boggling for most women to wrap their heads around. And I get it, right? Everything that we do in medicine, especially in this country, is driven on like, we can have a test, we have a scan, we have an imaging we can do, and that gives us a diagnosis, right? We need to check your blood sugar. We need to check your thyroid levels. We need to do a mammogram. Right? That defines how we kind of regulate prescribing, right? We check your blood pressure, right? We have all these numbers. Because perimenopause is so dynamic, these lab values are a snapshot. So I oftentimes will have women come to the clinic, that I had my primary check all these blood levels so that you could know them when I see you. And I'm like, cool, let's talk, right? And that is honestly what's going to develop the plan. I'm happy to look at them. And I think a lot of women want data, right? We have wearable watches, we have rings, that all this data. But the reality is the labs are a snapshot. Now, certain things, right? I mean, you want to look at thyroid function, you want to look at someone's ferritin, you want to look at their cholesterol and their blood sugars and all of those things that help give you the flushed out picture. But the hormone levels are, for a lot of times I say, hey, you're interested in what they are, great. Like the timing to do them is kind of early in your cycle. So days 1 to 3 of your period, that gives us an idea if you are having a regular cycle, right? A lot of women don't have a regular cycle in perimenopause. And so we're kind of like stabbing in the dark when labs are checked. But, if we can see that certain patterns, low estrogen, higher FSH levels, that can, if someone needs convincing, or it helps a woman to go like, actually, I can put my symptoms to a number and that validates it, great. Testosterone, we look at, right? If you're on baseline, if you're going to start therapy, it's good to know where we start. And then we look at those supplemental testosterone levels, because there's a physiologic range of normal that we want to keep women in, because there's not any good data that says, hey, jacking your testosterone up to a level of a man's is somehow beneficial. Most of the time it's going to have side effects that are not something women want to deal with. But I don't necessarily care if your number goes from 5 to 10 or 10 to 20. If you say, I feel really good, I'm like, great. Not only do you feel better, and I don't really care if that's brain fog, libido, mood, whatever it is, stamina in the gym, like whatever that positive movement is, great. You're also in a normal physiologic range for a woman. Let's keep it moving. There are definitely conditions in younger women where we're like looking at hormone levels more for diagnostic purposes. So if you're less than 40 and you're having very irregular periods and skipping months and having hot flashes and night sweats and brain fog and vaginal dryness, like we're worried about something called premature ovarian insufficiency. And so that is another case where the labs help us to make a diagnosis. But I would be cautious in someone who's undereducated in menopause care, kind of gaslighting women into being like, oh, your labs are normal, you're fine. And it's like, well, what does she say, right? How is she feeling? On someone on therapy, checking levels sometimes can be helpful, especially if maybe we're thinking there's not a response that we're expecting. So a woman that's saying like, I'm having hot flashes, I'm having night sweats, I've been on a patch, I've been on a gel consistently, and I don't know that I'm ramping the doses up and it's not seeming to have the effect. I may look at her level comparatively to where she began at, because maybe she's not an absorber. Maybe we need to talk about an alternative way to give her therapy. So we can use those numbers as kind of metrics to see, like, is this person an absorber? Sometimes women are super absorbers and they're going like, I'm having all these adverse effects of therapy. And so that can affect the way that we, the modality we use for therapy. So I would just say labs are information, but I'd be cautious about being like, that is what defines, do I need to adjust? Do I need to be on it or not? Because it's really more about how women are feeling,
Yeah.
It really
That's
is very individualized. It's very custom to the
Sure.
woman.
Mm-hmm. Absolutely.
Yeah. I mean, so you would say for the majority of women, HRT is safe.
Yeah. I mean, and the thing is, again, nuanced conversation, right, about what each woman's risks, benefits, et cetera, right? I mean, I have a patient, just, as an example, who's a breast cancer survivor. She had she had actually estrogen and progesterone negative. So it was a hormone negative breast cancer, meaning it was not sensitive to those, not that was the etiology of it, and she's been really struggling 10 plus years post all of this. She did all the things right. She had all the therapies. She's had no evidence of disease, clear. And she sat in front of me and said, I don't care if this buys me 10 more years of life and something happens as a result. Like, I can't live like this. And so those are nuanced conversations that someone has to have with someone they trust. They have to understand, my job is to talk risk benefits, kind of best case, worst case, and then come to an agreement. Because as much as, this society might say there are rules around what women can and can't do or should and shouldn't do for their bodies, like in my office, it's me and the patient, and that's our conversation, and that's what we decide. And so we also have a lot of non-hormonal options for those women, and probably more on the horizon as this becomes a hotter topic, to say, like, you don't have to live a poor quality of life, especially after you overcome something as, intense as a breast cancer, right? We have great ways to treat breast cancer, and a lot of these women are going to come through and have a lot of life to live after. And we want to make sure that we're giving them every option, so that they can have the highest quality of life.
For me, hormone replacement therapy was purely a quality of life issue. And it was a quality of life I didn't know I was missing. I think you just get used to maybe not feeling good. And then when I started the therapy, I was like, wow, this really significantly improved my quality of life, because I hope I have a lot of years left. I don't want to have good years,
Yeah. Yeah. Well, I mean, and when you look at how lifespan has changed, right? I mean, we used to go, I don't know, I'm horrible at history, but 100 years ago, we were not living to be 90 years old. And so women would go through menopause and they didn't have a lot of life left after that, right? So it's kind of like, well, we're not reproducing, not very useful to society. Okay. now many women are living 40% or more of their life menopausal. And what we know about the way that hormone therapy can affect long-term chronic conditions, osteoporosis, recurrent UTIs, dementia, cardiovascular disease, right? So not just quality of life in the moment when you're symptomatic or you're having those symptoms or going through that transitional time, but to say, hey, I talk a lot to my patients about, I don't necessarily, when we're talking about metabolic changes and what hormone therapy can do for them, I'm not talking about your beach body for next year. I'm talking about, what do you want to do when you're 75? Do you see yourself traveling, hiking, cycling, whatever their passions are, is saying like there's an important part of preventative health in optimizing your hormone health, right? For those things. And those are the things that are going to, affect women exponentially more than men, right? I mean, 7 times more women are going to die from cardiac disease than the top 5 cancers combined, right? And so we have good data about initiating hormone therapy within 10 years of menopause and having 40+% reduction in all cause cardiac mortality for those women. So, it reaches beyond the hot flashes and the mood and the sweats and the sleep and all of those kind of things when we're talking long-term health too.
Well, I think about the urgency of getting on HRT. I think a lot of women, they're either like in denial. I'm not sure that's what this is until they figure out that's what this is. And then there's this other flip side that's like, do I need to be? Is it that urgent? And they kind of wait. But you probably know who Dr. Marie Claire is. She kind of has become really outspoken with.
Sure.
Thank goodness people are talking about it. I mean, she's like, people are starting to take note of women's health, and it's very slow moving, but it's happening. And everything she says sounds kind of like what you're saying is everything will be better for you in the long term if you do start taking care of this sooner than later, right? In your menopausal years. Is there back to that? Is there truth?
Definitely. Right. I mean, so when you think about the things that we're talking about cardiovascularly, bone health, those kind of things, right? These declines start well before menopause, right? So we peak our bone health, our bone density peaks in our late 20s, early 30s. And so depending on what that peak is, I mean, a lot of us, I was a college athlete, so I rolled my eyes so hard going to the weight room. I had thighs that were too big to put on the cool skinny jeans at the time. So you got a gap in your waist and your jeans can't go over your legs and you're just mad. But I think that, thank God, because I have a family history of osteoporosis, that I was laying down some benefit, right, at a time where a lot of my friends and none of my sorority sisters were leg pressing in the gym. They were on the elliptical, right, reading a magazine.
Cardio queens.
Yeah, yes, cardio queens, right? So we peak our bone health in our late 20s, early 30s. And so you can imagine that, we have about a 10% decline. It's a pretty swift decline in menopause as far as bone health goes. And some women can expect to lose 20% of their bone density kind of in that early, in early menopause, from peri to early menopause. And so that's huge, right? So the more that we can be proactive to prevent that decline, same with like our, what's called the intima or the lining of our blood vessels. Estrogen keeps that supple and soft and helps with perfusion. And so if we go, if someone is 5 years post-menopause or menopausal, there are changes that have happened during that time that, unfortunately, starting hormone therapy at that point, it doesn't undo changes that have already happened in our body. Now, it can still prevent that slope from just being like this down, right? We can kind of level it off, right? And so that's why there's so much talk about this 10-year window of opportunity, right? And trying to get women. Now, that's 50 to 59. So, if you're perimenopausal and you're like, my gosh, I don't know that I feel awful, but like I'm scared that I'm going to miss my window. No, it's okay. Take a deep breath. I mean, I have girlfriends that are like, so what's the trigger? When should I start? And I'm like, my crystal ball is cloudy. I don't know when you're going to hit a point where you go like, this is not tolerable or these symptoms are not tolerable. But I'm like, okay, well, at minimum, if you're not having a period, then we should have a conversation. Or, like I said, the data we have is 50 to 59. So that 10-year window of menopause. But these changes are happening in mass loss, right? Most women, 8% of lean mass loss over the menopause transition. And so for women that are going like, I want to optimize my lean muscle and I want to stay strong so that I'm functional and I can do these things. It's like, yeah, being on the earlier side before we're trying to like make up lost ground. And it doesn't mean you can't continue to get strong as you age. Like you guys know this probably better than most, but you can continue to make those gains. It's just harder, especially in the absence of estrogen.
So that's what's going to help us in the long run. Cause I was one of those that was like, am I too late? Am I like, I got to get on
Yeah.
this. Like I just felt this. And then I kept having shows and I kept worrying that the fluctuations were going to mess with my, you know, my shows and my peaking and all of that stuff. And so another question is, does it sometimes, we kind of touched on this, does it sometimes get worse once you start HRT before it gets better?
Yeah, I mean, some women will, and a lot of it more, this is anecdotal than probably evidence-based science. But yeah, I've had women say, oh my gosh, my hot flashes got worse for a week. Like, what is
Yeah,
that?
because that's how I
You know?
felt a little bit. Yeah.
Well, and also like women are coming from different things, right? Some women are coming off of a contraceptive, right? And switching to menopause dosing. Some women are nothing on board and coming to something. Some women have been on, maybe compounded stuff and I'm switching them over to more of the FDA kind of approved stuff. And so a lot of it depends on your start point. A lot of it depends on environmental factors, right? We all know stress can exacerbate all of these symptoms, right? So you could be completely well controlled on your therapy regimen and then somebody gets sick or somebody loses their job or, a kid is struggling in school. And that these women come to me and they're like, I'm hot flashing all the time now. And it's like, well, does that mean that we need to adjust your therapy? Maybe not. Maybe this is more of a, hey, this is transient and we've got to just be patient. Everyone's favorite thing, right?
That's what Lacy actually said. That I was confiding in her. I was like, I don't know. Everything feels worse. And she's like, well, I think you should give yourself some grace here because it was my brother who passed away. It was his birthday and he passed away the day after his birthday. And I was dealing with that, as I'm dealing with the hormonal changes and there was something else she mentioned in there too. She's such a good friend. She was like, let me just point this out. And I was like, I didn't even think of that. I didn't even think of like the other factors. It's like you just go to straight, like, let's just blame it on this, and like, but there's so many factors.
Yeah, we like things to be neat and tidy. Our brain likes things neat and tidy and like one to one. And the reality is that, I always joke with women because they'll say, I feel better or whatever. They're coming in for follow-ups and they say, but I'm still irritable. And I said, well, you know what? Your estrogen patch or your gel you can't wipe that on the people around you, right? It's not going to make someone at work who's, mean or, whatever, giving you problems, make them kinder. It's not going to make your kids listen more. It's not going to make your spouse, pick up the dirty socks off the floor that's pissing you off, And so I wish I could say, yeah, this is magic, but it's science and it's science for you and your body. And my hope is that it gives women the foundational support to manage the things that are going on around in their environment and to, as best they can, try to, set themselves up for success, right? Personally, social media, it's great. I think it's great to connect people at a period of time, kind of post-pandemic-y, new little babies, work stress, where I was like, every time I go on social media, I see something that like sticks in my brain and is bad. And then I perseverate on it and so I had to exit. Right. And so like, I know that's how I have to set myself up to not have worse sleep, worse anxiety, all these things. And so some of that onus is on ourselves to kind of be like, okay, I know how I can set myself up for success, but we can't control everything. Right. And so we have to just, again, have grace with ourselves to say like, I'm doing the best I can. If I can say I'm putting in the effort for all those foundational building blocks we talked about at the beginning, my sleep, my nutrition, my movement, my stress management, if I'm doing those things and I have a good relationship with my provider and I feel confident that I'm on or getting to some therapy regimen that's going to help support me so that I can have the kind of physiologic kind of groundwork supporting me so that when I'm faced with this kind of upheaval and the stuff that life's always going to throw at us, I can say, no, I have firm grounding to know that I can manage this because, all my neurons are appropriately bathed in the right stuff.
That was really helpful. A lot of ways to think about things. This is going to be great for the girls to listen to.
What's your biggest words of advice for all the women out there that are
Sure.
listening to this?
Yeah.
Big majority are going to be masters, 40 plus competitors. And you being an athlete is also a reason. The minute I saw it, I was like, oh, she works out. She's an athlete. I love that because the athlete mind really understands the athlete mind,
Yeah, for sure.
And so what do you have to say to all of them?
I mean, I think the thing that I would say that I think is kind of the universal, as women in high performing women, whether that's family, job, sport, career, whatever, we have been fixers. We have had to navigate systems that are not designed for us to excel. Just in general, women, that's just how the world is set up. So we've always been able to fix things, right? Oh, I found a workaround. I know how to hack this. I can do 100 things because I can. And I will, because if I don't do it, no one else will. What I want women to hear is you cannot fix yourself in this time. First of all, you're not broken. So you don't need to be fixed. Want women to be able to say, okay, something is not firing. Something is not clicking. And doesn't mean you can't focus on maybe trying to make some changes to your lifestyle. If you go, oh, I've been slipping. I haven't been doing my workouts. I haven't been going to therapy. Haven't been doing my me time, my meditation. If those things are things you can adjust, great. But find someone who understands menopause and women's hormonal health and metabolic health at midlife, whether that's looking through the NAMS certified, North American Menopause Society, finding a certified provider. Dr. Mary Claire Haber has through the Pause Life community, you can type in your zip code and find a provider, but connect with someone that you can have a conversation with, because the reality is you can be the best exerciser and the best eater and the best meditator in the world. None of those things are going to reproduce estrogen to stimulate the receptors that are the root cause of why most of us are feeling off. So as much as we want to be super women, and we all are, because we're just doing the things, this is not something I want women to feel like they need to fix on their own, because it becomes very insular and very isolating. And, this is a time where we need to lean on help from outside, even though most of us probably don't like that. We don't want to rely on somebody else. But I just strongly encourage women to find a provider that listens, that is willing to work with them and adjust things if they feel like it's not working for them. And so that's number one. And number two is probably, welcoming people in your life into the conversation. That's maybe not just your girlfriends at girls' dinner, everybody kind of talking. But if you have, I have a lot of women that have teenage daughters and, sons too. I'm sure they're probably but is starting these conversations, right, with the people in your life. If that's a partner, I have partners come to visits, and be involved in those conversations. Yeah.
My husband came on a video visit.
Yeah. And so sometimes I enjoy that, because those are the people that are going to support you through this, right? And especially if they are not women, they don't know. And they don't know how to help. And so they're going to go to their default, which is, some of the times the things that annoy us the most, right? It's no, I actually don't want that. This is what I need. So reach out. Don't have to fix it. You're not broken. Involve the people in your life in the conversation so they know how to best support you. The world needs women to be high functioning. And so the fact
Amen.
that, this should be on everybody's radar. I mean, as anyone who employs women in midlife should be I need them to be good so that because they're going to be the ones that are going to keep, our organizations and companies doing well. I mean, there's a huge dropout rate of women in midlife from high mental functioning jobs. And that's crazy. That's crazy. So those are my two big ones, I think, as far
Very
as takeaways.
good.
I mean, it was freeing when I came to you, because I did feel like I like I mentioned before, some of my clients, I feel like they were in that spot where they're just trying to figure it out, or they think I can. I'm not a doctor, barely know how to do it myself. That's why I've given many of them your contact info, and it's it's freeing to let go, and it's freeing also because sometimes I'm gonna be real. I think my husband probably thinks I'm crazy. I think he doesn't, but my mom, I'm sure, when I was 11 was going through this, and we didn't know what that was. And my dad legit thought she was like, I think he wanted to take her to like a mental ward. Like,
Yeah.
we
Yeah.
have this knowledge now, and your partners need to be on board with this. And I brought Mike to that visit with Dr. O'Brien, and she was, happy to have him there. And he learned so much. And because he needed to, there's so much to learn in women's
Yeah.
health when we navigate this. And it helped open his eyes to like what I was going through, and he could better support me knowing, all the information that Dr. O'Brien shared with us that day. So yeah, I love all the things you touched on.
Yeah. Yeah. If we don't understand what's going on with our bodies, I mean, they're lost. We're lost. They're more lost, right? It's blind leading the blind, and that doesn't go well. Yeah.
Oh, what a great talk. Thank you so much for coming
Yeah.
on and teaching us about that. All right. I think that's a wrap for today, guys. Thank you for listening to the Masters Bikini and Fit Model podcast. As always, I want to tell all of you that I love you.
And I love you too, and we mean it.
Bye, guys.
Thank you for listening to the Masters Bikini and Fit Model podcast. If today's episode inspired you, please share it with another athlete. Follow us on Instagram, and remember, your best years are not behind you. They're still being built. We'll see you next time. Until then, we love you and we mean it.